The fast view option is fantastic as it gives you a 3D, 3-plane, contiguous set of images, coronally, sagittally, and axially. That is done as a non-breath hold. You landmark on the patient's chin, and it will essentially scan from about the middle of their head, typically through their pelvis, depending on the patient's height. That is done as a non-breath hold, off of which you would position your breath hold localizers. So we have two sets of localizers. We'll have the fast view, which is the non-breath hold, and the true fist breath hold that we strategically set up off of the fast view. You always position breath hold scans off of breath hold localizers or other breath hold scans acquired before it, and you always position non-breath hold scans off of non-breath hold localizers. This particular scanner does not have a fast view, so we're simply going to bring over a localizer, open it up, and make sure that the coils where the patient's positioned are on, and apply it. All of our abdominal imaging is scanned at table position isocenter. Positioning mode, excuse me, isocenter. And the purpose of that is, as with any long axis body part, you want the center of that body part to be at isocenter, or the center of the stack of slices to be at isocenter. So for the long axis imaging, like coronal T2 HACE of the abdomen, you would want to make sure that your abdomen is at isocenter, so the scanner will bring the center of your field of view to isocenter. When you do stacks of slices, perhaps sometimes you'll be doing multiple stacks. You want the center of those stacks to be brought to isocenter, so you have the best homogeneous signal, both for FAT-SAT purposes and for artifact purposes. Alright, so we're going to do our first breath hold localizer. Okay, Sarah, we're going to get started. Just remember, whenever you take a breath in, try to take in the same amount of air each and every time. This is critical because it puts your diaphragm back in the same position. You don't have to take in a very deep breath, just something that's comfortable for you. Please don't breathe until I tell you to breathe, and above all, be as consistent as possible. An easy way to get around this is perhaps think of a number like the number 3, and as I tell you to take a breath in, count to 3 in your head and stop your inspiration every time you hit the number 3 in your head. That will pretty much ensure that your diaphragm lands back in the same position, okay? Alright, so right now, please take in a breath and hold it. Notice that I don't hit continue the second I say hold it. It's really important that you let the patient finish, breathe, taking in the inspiration and stopping. A lot of our scans, they will start to acquire as soon as you hit continue, and if the patient's still in the process of holding their breath, then you can have a little bit of motion on some of the slices. So whenever you tell a patient to take a breath in and hold it, give them just a second to finish the task and to actually hold the breath and then hit continue. Alright, so our first set of localizers came up. There's some coronals. There's some axials. And there's a sagittal. Right, so if we're not happy with any of them, we have the ability to scan as many localizers as we want, just like with MSK imaging or any other type of imaging. So we'll bring down our localizer, perhaps go down to just one slice group. I'm going to do some axial slices. Put it more through the liver. Maybe add a couple. You can tailor this to your patient. Some patients will have extremely long livers. Some patients will have really short or higher livers. You may need to add a couple of slices, play with your distance factor. Again, it's not for the radiologist, it's for you. So that way you can feel more confident setting up your actual sequences. So here's our axial slices. I'm going to add a group and do some coronal slices. open up my rectangular field of view to 100%. Very good. And apply that. So since it moved to the table to isocenter, so here's the center of my group, and here's the center of my long axis. It's moving this very spot here to isocenter. And since it was not there a moment ago, it has to go through the process of tuning and, most importantly, reshimming, which you just finished. And now we'll do our breath holds. All right, Sarah, again, please take in a breath. Hold it. Breathe. So if you notice, whenever I do the breath holding, and I do this for any intercom system, is, Sarah, I'm just going to give an example for a moment. You don't have to follow my directions, okay? So typically I will depress the intercom and say, okay, take in a breath, and then I release it so I can hear them. And I do that because I found way back when I started doing abdominal breath holds that sometimes the patient wasn't ready, or they had to quickly swallow or cough or clear their throat. And if you just simply hold the button down and say, okay, take in a breath and hold it, don't breathe, and then you release it, you may have missed them saying, hey, wait a second, or starting to cough or clear their throat. So I found a long time ago, and I try to tell everyone this, that if you simply hit the button, tell them to take a breath in, release it, you can hear them, and then you can say, okay, and hold your breath. It gives you an opportunity to potentially hear your patient trying to communicate with you. All right, so I just wanted to point that out to you as well. And that's a really good habit to get into for any and all breath holds that you do. So here are our new localizers. As you can see, I have a little bit more of an overview of the liver coronally than I did on the initially acquired localizer, because remember, those are pre-planned, and depending on the patient size, you may or may not get enough slices through the liver that you want. And axially, again, I have it through a good portion of the liver. Okay? So how I typically operate is I'm going to set up my Axial T2 Haste right now. So I'll keep an axial image up in one of the segments, doesn't matter which segment, and then I'll keep a couple of coronal images up in the other two segments. One coronal image, I'll put the highest point of the liver and diaphragm, and in another segment, I'll put where I see the iliac crest, because for our protocol, our axial images have to cover from dome of the diaphragm to the iliac crest. This way, I'm not sitting here as I'm setting up slices, constantly flipping through images. I know that I have to cover from here to here. That way you're not wasting time, you're not flicking through, you have 3 images off of which you know you need to set your images. So we'll bring our axial images up, and you can either look at it on slice mode or package mode. I'm going to choose package mode for now, and I'm going to go probably about 1 slice over the diaphragm, just to compensate in case she does in fact change her breathing a tiny bit. So I'm going to start my slices here, and I'm going to protocol stack minus to see if I cover. I don't quite cover, so I'm going to add probably 4 slices. Again, start up here, protocol stack minus, and see if I cover, and I do. Okay? Then we'll go protocol stack plus, start where we want, then I'll get my field of view and position it accordingly. Now you notice I'm not flicking through, it's just an easy process. Make it easy for yourself. You know where you have to start, you know where you have to end, have both of those images up, have your second localizer for your field of view up as well. Prescribe your number of slices, do a practice stack minus the way we just did. Does it cover? If it didn't, add a few more, start again, and stack minus again. If it does cover and you're happy with it, start back at your starting position, check your localizer, and you're good to go. So that is the prescription of the slices. Now we have to make sure that any adjustments we made, which include adding slices, still give the patient a breath hold that they can manage. So here we see the acquisition time of 52 seconds. We also have 2 concatenations. So if you hover over on Siemens, the acquisition time, it will tell you that it's roughly a 22-second breath hold. Okay? If the patient cannot do 22 seconds, you can add a 3rd concatenation, and if you hover over it, that's now a 15-second breath hold. And as you'd imagine, if I add a 4th, it'll get even shorter, down to an 11-second breath hold. Obviously now you have to do 4 breath holds as opposed to 2. But you have to let your patient be your guide and see what they can give you. So she's young. I have no problems with expecting her to do a 22-second breath hold. Okay? I want to make a note that if you do add more concatenations, do not touch your TR. This is a T2 weighted haste image. You need a little bit longer of a TR, both to help provide you with the T2 weighting as well as manage SAR issues. So if you're going to go to 3 concatenations, just leave your TR the way it is. And if you do SAR on this particular sequence, you now have the ability to perhaps make her hold her breath for about 17 or 18 seconds. So one of the ways that we manage SAR is by increasing the TR. So if we went to 1500 TR, she's only holding her breath for 17 seconds. Okay, so you don't want to minimize your TR or decrease your TR if you're utilizing concatenated sequences. Go back to where we were. And then the very last thing you want to do is make sure that your coils that you want on are on. Typically, a lot of these scans are on auto coil select. So as you navigate up and down your field of view, it'll turn coils on and off accordingly. Sometimes you'll be right at the cusp of a coil where you think, hey, should that coil be on? If you are really that hesitant, then you can turn that coil on. Just bear in mind that the more coils you have on that aren't contributing signal, they're ultimately contributing noise to your image. So I'm going to trust the scanner. I have a fair amount from the end of the slice to the end of this active spine coil element 3. So we're just going to leave it as it is. And then I typically try to tell the patients that the table's about to move. Okay, Sarah, the table's going to move a little. And then you're going to hear some noise for a moment.
Greetings.
Okay, that was Sarah, not Siri. Thanks, though.
Thanks, though. How embarrassing.
For you.
Burn.
Yeah, touche.
Second one of the day.
Okay, Sarah, right now, please take in a breath and hold it. So these are single shot scans. They're HASE. HASE stands for half Fourier acquired single shot turbo spin echo. So every TR, you get a slice. Breathe. How are you doing? No problems with that breath hold? Great. So a couple things I want to point out to you. Some scans will prompt you to hit the pop-up window with a continue button option. Other scans will prompt you, if you look down here in the bottom left corner of the screen, it says press scan in the inline display when the patient holds their breath. So now this, if you hover over, will tell you that's the scan breath hold button. So now you have control over, take a breath in, hold it, this is where you hit continue. If you don't see a pop-up come up with a continue screen option, then typically you'll see this sign down in the bottom left-hand corner, okay? This is your inline display. Here's your inline display open and close. Most scans that will prompt you to utilize the inline display will automatically open the inline display for you. If you see this sign and you don't see the inline display up, then simply come here and open up the inline display. When the inline display is open, you have two options to view the inline display. This has the frame on it, and if you right mouse click and deselect frame on, you just simply have one box with two scan options, and that is either scan breath hold or stop and continue. Okay, so however you'd like to visually see it, it's totally up to you. There's no right way, wrong way. It's completely what your preference is. Do you like chocolate ice cream or vanilla? That's it. Okay, so when I'm ready, I'm going to ask her to take a breath in and hold it, and I'm going to hit the scan breath hold button. Down in the bottom left hand corner, you'll see what it's scanning and the countdown clock. So not only the countdown clock shows you how many seconds left to your breath hold, but it'll tell you if it's scanning the first of 2 concatenations or the second of 2 concatenations or the first of 3 or the second of 3, so on and so forth. All right, Sarah, please take in a breath. Hold it. Again, notice that I gave her a second to actually perform the breath hold and to hold it. I hit the scan button, and drawing your attention down here to the bottom left-hand corner, it's scanning the breath hold. It's scanning the second out of 2 concatenations, and that's how many seconds are left to the breath hold. Any questions so far? Breathe. Alright, so here's our first set of images. So, if she were a real patient, incidentally, I meant to mention this to you. If she were a real patient, here's the top of my coil. I would have gone in and slid her coil up a little bit. Okay? But in the interest of time, we did not do that, since this is a lab.
Wait, can you say that again?
Yeah, so Siemens will show you graphically where your coil segments are as it relates to the patient's anatomy. So you see how this is the anterior body 1, body 2 elements. So the top of the body array coil barely just makes the top of the liver. And look how low the coil is actually sitting towards the pelvis. We don't need a lot of signal down here. We would want more signal up here. So again, if she were an actual patient, while I was prescribing this and saw this, you would go in, you don't have to move her, you just have to pull the anterior body array coil in the direction where it's lacking. So in her case, it would be, I'd be moving it cephalad up towards her head. Does that make sense? Okay. And when you're QCing the images, in her case, as we come cephalad, you'll start to see signal diminished. See, I have a nice bright signal where the coil is, and now you're not getting that great of signal up here. Also, as a QC check, you want to make sure as you're scrolling through your axial images that you're not seeing jumping of the liver or other anatomy. So specifically, you'll notice it more up towards the diaphragm, towards the top of the abdomen, where you'll see potentially liver and then just lung, and then a big chunk of liver and then maybe a little chunk of liver. That means that she was inconsistent with her breath holds from one concatenation to the next. However, she did a great job with consistency because you see how smooth and seamlessly we're scrolling through the liver without any jumping anatomy. Can everybody appreciate that? It's hard to show because I don't have an example of the opposite right here, but perhaps we'll have her do something differently to show you. But we're going to continue on with routine. So when it comes time to do the second stack, simply drag down what you've already done, open it, let me do that again for you, drag down what you've already scanned, open it up, protocol, stack minus, and apply. It's that easy. No more flipping through images, you know where you started, you know where you have to end. Your second localizer doesn't change, just simply drag it down, open it, stack minus, and apply it. Okay, Sarah, please take in a breath. Hold it. Breathe. Obviously, if your patients are a little labored with their breathing, you may want to give them a few extra seconds in between your breath holds. If they're perfectly healthy and fine, you can go right into the next breath hold after a few seconds. Again, please take in a breath. Hold it. Breathe. So here's our second stack. Down to the crest. Okay. Now we wouldn't send both of these series over to packs. We would want to combine them and send them as one series of axial T2 haste. So you can go to your viewing card, click on your first set of axial images, and then right mouse click select series. Hold the control key down, select your next set of axial slices, right mouse click select series, patient save as, and then label it how your doctors want it labeled, which in our case is the word axial T2 haste. If it hollers at you and says, hey, you already have another scan in your user tree named exactly how you typed it, just say cancel, and then you just have to simply hit the space bar. You'll see some people put an asterisk or a dash or an underscore, however you like. It's not necessary. Simply a space bar is enough of a character change for the system to say, okay, that's a new name, and just hit OK. So next we're going to set up for our coronal images. Bring over our coronals. Again, our field of view has to cover from dome to crest. So I'm going to leave these two images up here as our second localizer. I'm going to use... Yes, Sarah? What's that? Oh, Diana's the DJ and I guess she failed.
Oh, sorry. What does she want? Fleetwood Mac.
Fleetwood Mac.
Oh, yeah. How do you spell that?
F-L-E-E-T
There you go.
W-O-O. I sound like the goose from T-double-E-double-R-double-I-double-F-double-I-double-C.
I
Gotcha. Okay.
There's a lot to learn. Someone's gonna watch this video and be like,
Localizer's up here, and I'll position the coronals off of the axial, typically off of sort of the widest portion of the abdomen that we can see. Probably it here. We'll open this up. So this particular scanner for this exam is built with a field of view that's large enough, but also rectangular field of view is utilized to about 75%. So if I'm not quite covering down to the crest where I want, I'm not going to bring my field, I'm not going to lower my field of view, because if she changes her breathing a little bit, then we're going to clip the top of the liver. So instead, I have two options. I can open up my field of view read, but that's going to decrease our resolution. When I have the ability to open up the rectangular field of view, that's what I'll do. So we'll give that a few clicks open, because that does not affect our resolution, but it will now allow us to cover from just above the liver to the crest. Okay, now we have slices to contend with. we clearly need more slices for her. So let's just throw a random number up there. All right. Now, as long as you get to the anterior abdominal cavity, you're perfectly fine. Same thing posteriorly. You do not need to cover past muscles in either direction. They're not evaluating the muscles, they're evaluating the abdominal viscera. If they did want to evaluate, for whatever reason, these muscles, they'll have it axially. So don't waste the patient's breath hold time or your time and increase the slices to cover out beyond the muscles or the skin. So once you have your slices set, your field of view set, you're pretty much ready. The only thing you have to do at this point is check to see if the breath holds are manageable in time since you've added slices. These are 26 seconds. That's a little much for almost anybody. So my first thought would be to concatenate one more. So let's do 3 concatenations. So that'll make it 3 breath holds at about 18 seconds apiece, which should be perfectly fine. You're going to feel the table move. Okay, Sarah, we're going to get started again. So right now, please take in a breath and hold it. Breathe. Again, please take in a breath, hold it, breathe, and again, Sarah, please take in a breath, hold your breath, you can clearly see Sarah's breakfasting coffee.
Iced tea.
Ever so obstructively in her stomach.
No coffee.
Breathe. Okay. So as a QC check, notice again how the liver, the diaphragm seems to stay right where it is and you're not seeing this big jumping effect. Okay? I'm going to show you an example of when a patient is not consistent with their breath holding. Hey Sarah, we're going to do 3 more breath holds. I want you to hold your breath differently each time. Like be real. They're only about 9 seconds, so you can hold your breath very, very differently all 3 times. That would be great, okay? All right, so take a breath in and hold it. So right now it looks fine because it's only the first concatenation and everything seems to be good. Breathe. And again, just be really inconsistent for the next 2, okay? All right, take a breath in hold it, and sometimes patients, despite repeated coaching, they will not follow directions, so you really have to breathe as pleasantly as possible, just repeatedly coach them at least a couple of times before the exam even starts. Practice with them before the exam even starts. And then typically, before I do my first breath hold, I give them one more reminder. And again, take in a breath, hold it. So you see on that first concatenated breath hold, everything looked fine. And if you weren't paying attention, then the second one also would have looked fine as it was reconstructing. Same for the third. But now, when you bring it up to check, see how it's different? Mm-hmm. And if we were doing more slices, you would actually see it even more exaggerated, because it would be like every third slice would be up and down, up and down, up and down. So not only is this not ideal for the radiologist to look at, and quite frankly, it would drive them insane, but also from a diagnostic perspective, when you're scanning it axially, it really diminishes how diagnostic the scan is, because the slices aren't going to line up and they could miss anatomy in between or pathology. Okay? So that was just a little example. I'm going to delete that, make it go away because it's giving me a headache, and we'll just look at it from there. Okay, so next in our protocol, we do a thick MRCP slab. So it's one slice, super thick. And for our sites here, once we define the biliary tree, we run the slice 5 times. And the whole purpose of running it 5 times is because there's peristalsis that takes place within the common bile duct. And if there's an area on the first slice of the common bile duct that looks a little dark, you wouldn't want to mistake that as a stone. And perhaps it's just an area that's not filled or in the middle of peristalsis that's moving the bile along. So that's why we run it 5 times. Because typically if it is a stone, it'll stay dark in that same area through all 5 images. Okay. So there's different ways to get to that point. I'm going to show you what I think is one of the easiest and most effective ways to get your MRCP slice and angle. So I've actually built in what I call an MRCP scout. It is the same exact sequence as our coronal MRCP thick scan. I just simply labeled it scout as sort of a guidance for people. So I'm going to bring that over. On my coronal image, I'm going to find my common bile duct, which is right here. And I'm going to follow it down, and you can see where it meets the pancreatic duct.